Is it afternoon or is it still morning? Good morning. I have the pleasure of introducing our speaker for today. Dr. Jialin Mao is an assistant professor in the Department of Population Health Sciences at Weill Cornell Medicine. She's an epidemiologist with a background in medicine. Dr. Mao received her medical degree from Shanghai Jiaotong University School of Medicine and completed part of her residency in general surgery at Ruijin Hospital in Shanghai, China. She received her Master of Science in Epidemiology from Harvard School of Public Health and her PhD in Epidemiology at Columbia University Mailman School of Public Health. Her expertise is in research of medical devices and interventional care for chronic diseases. Her current research focuses on health disparities related to medical devices and interventional care. She is also interested in improving methods and infrastructure to support the evaluation of device and interventional outcomes and associated disparities.
Thank you. Thank you, Adina. Everyone, welcome in the class. I feel really fortunate to have the opportunity to come here for this talk. And it feels a bit like homecoming. I feel like time flies. I've just graduated almost yesterday, and now it's actually 2 years now.
Would you mind just speaking up just a little bit?
Okay. Can everybody on Zoom hear me? Well,
yes, we can hear you well.
Sounds good. Thank you. Yeah, so very happy to give this talk. And my talk today is on segregated and differential treatment structural inequity in interventional care. I know there are a few phrases in this title probably need more clarifications. Hopefully they'll become clearer as I move through this talk. Okay. I'll just use the mouse. So I'll start from a bit of my background and research interests, and then spend some time talking about some recent and ongoing work related to this topic, and lastly, touch on some future directions. I was actually born and raised in Shanghai, a very large metropolitan city in China. So large, it really skews my definition of large cities. And I went to medical school there. We follow the British system. We enter medical school directly after high school. It's a 5-year program. And I was actually in a integrated 8-year program, which means after the 5-year medical school, you directly went on to a 3-year integrated residency plus research program. And it was actually just after getting my medical school finished, entering into that later part, I realized they asked us to do research, and there's research requirement to exit that program. But then there was not really any training or support for research, in a sense that they don't teach us how to do research. They just expect that you learn how to go. And that really made me a bit like, I really want to do it properly. I really want to do it well. And also there were a few career things happening that made me think, okay, maybe I'll just take a pause and do a research training, and then we'll come back and think about what should happen next. And that's when I went to Harvard School of Public Health and did my master's there. And it was after the master's, it came to me that the process of finding a problem and trying to solve the problem, it really brings me joy. And I think, and plus I'm not extrovert enough to enjoy practicing medicine. So maybe this would be a better career fit for me. And it's around that time, there was a position opening at Weill Cornell that this position would be working on studies looking at medical devices and interventions. So I feel like that really closely matched my interest. So I decided I'll take it and see where it takes me. So I was there. I was on an analyst research associate role for about 3 years. And that's the time I feel like I do like it. I want to stay in this business or academia. And and on top of that, I would really want to do something that I want to do. I want to lead a study instead of just being an investigator on someone else's study. And that made me decide to pursue a PhD. And that's when I crossed the Central Park and came to Columbia. In fact, many times, because I kept working there during those 5 years. But I think the 5 years at Columbia is really the time period. Now that I think about it, it's really the time period that I started to put everything together in terms of what area I want to focus on, the theoretical frameworks behind those studies I want to do, how I want to do them, and how I want to really move my career forward. So yeah, I kept working there. I was a little bit crazy back then. I'm better now. And at the same time, during the same time, I was hired internally during that 5 year, I was hired internally as an assistant professor. Also had my family and my child actually during the 5 years. So it was pretty efficient 5 year. And after graduation, I basically just wanted to continue working there. And here I am talking to you about my research. So my research interests, they are broadly relevant to medical intervention and devices in chronic disease care. While this talk is going to be mostly focusing on cancer, I do quite a big chunk of work in cardiovascular disease, and there's also some work in the past that I did with other disease areas. And I think a lot of the things that I'm doing now is really not disease specific, but we'll get to it later. I like to break them into 4 brackets. I started working mostly with other investigators on studies on real-world outcomes of medical devices and interventions and the impact of provider characteristics, such as physician characteristics and hospital characteristics. And then as my career evolved, I spent quite a bit of chunk of time working on methods and infrastructure, and I personally have a very strong interest in disparity research. So before I dive into the disparity part, I'd like to just spend a few minutes on this part because I really did quite a bit of work in it, and I think there are good lessons from it. So what my work is mostly focusing on is how we can leverage different data sources to support medical device and interventional research. And recently I've been working on whether electronic health records are useful to our research. That's actually my case from NHLBI. And also I'm working with some informatics colleagues to see if we can integrate somehow our frameworks and our methods to facilitate the research. There are things that worked well. There are also things that didn't work that well, to be honest. As much as I love to talk about things that didn't work well, I think I'll just spend the limited time on things that worked. I would be happy to come back and talk about things that didn't work later if there's interest. So we're really during my work that really moved from feasibility to the fruition stage is we worked with the Society of Vascular Surgery, and I worked with some vascular surgeons to, they have a national registry of that's called Vascular Quality Initiated. And we used indirect plus direct linkage, a hybrid linkage method to link it to Medicare claims data. Because the registry has difficulty in collecting long-term health outcomes. So then we basically came up with this solution to try to get some important long-term outcomes from the claims data. And that really moved from, I think it was in my early years I started working on this. It really moved from the stage where doing feasibility in just one module, and then we moved on to scale it up to different modules. And now it's becoming a very mature resource that a lot of investigators are using for their research. You can think of it as we made a SEER Medicare in the vascular world. And on top of that, we move things forward. We even created standardized outcomes so that people don't have to, so that there's no inconsistency between things, and we validate those outcomes. So there are 2 studies recently that came out that really use this mature resource, use this data source to look at devices that have been linked to some controversies in safeties. I'm very proud to say this paclitaxel-coated device study just got selected as one of the 3 winners of the best research published in EJBES last year. And it's where we use this rich source of data to reconcile finding and more rigorous methods to reconcile findings between meta-analysis of clinical trials and observational studies. So going back to the disparity, I would like to just say a few words about those 2 terminologies before I move on. Disparity, health and healthcare disparity really refers to differences in health and healthcare among population groups, which is usually linked to social, economic, and or environmental disadvantages. And that usually lead to higher burdens of disease in those disadvantaged groups. And in equity, it's actually a different concept. It's some form of injustice or unfairness. And I think these 2 concepts, they are actually very closely linked because a lot of the disparities, they stem from inequities. And the reason I got really interested in this part of work is because I've worked with many medical device contacts and a lot of disease contacts with various investigators. And there's some pattern that just repeatedly showing up. Racial and ethnic minority groups and those from low income and high poverty areas, and sometimes females, they were less likely to receive newer or less invasive devices, technologies, or procedures, such as in cancer care, there's robotic device for a few cancer surgeries, like prostate cancer surgery, colorectal cancer surgery, lung cancer surgery. And there's also, for example, in lung cancer surgery, you can get nowadays for very small cancer, you can get a sublobar resection, just taking out a smaller piece of lung instead of an entire lobe of lung. We need higher specialized surgeons to do that. And those minority groups, those disadvantaged groups, they're usually less likely to get that. And outside of the cancer contacts in vascular world, there's also the devices used in to treat vascular disease. The disadvantaged groups are less likely to actually receive those device-based procedures versus open procedures. And then also in orthopedic care, they are less likely to get total ankle replacement instead of ankle fusions. And when they're treated for those diseases, they tend to have worse short-term and or long-term outcomes. And that just made me think that something fundamental is happening. There could be, I am thinking, there could be some unfairness that's happening that's leading to all these differences. And that really led me to the previous research on racial and ethnic disparities in robot-assisted radical prostatectomy. This is actually part of my dissertation. Some of you might have heard about it. It's currently in revised resubmission at a journal that hopefully we can announce in due time. So a little bit background. Prostate cancer is the most prevalent cancer among men in the US. And currently with the screening paradigm, about almost 80% of the cancer, they're diagnosed at the localized stage. By localized, we mean that the cancer is completely limited to the prostate gland itself. And for localized prostate cancer, the cancer survival rate is about 95%, pretty good at 5 years. For most localized cancer patients, except for a proportion of them who have very indolent cancer, the recommended treatment is usually radical prostatectomy. While the survival is pretty good, radical prostatectomy is associated with some morbidities, including bleeding, injury to organs, and cardiovascular events, as for all the major surgeries. And the systematic review put the complication risk at about 8 to 18%. And these complications may lead to prolonged length of stay, increased readmission, and increased healthcare resource use and costs. It has been shown before that Black and Hispanic patients, they had comparable survival, but worse short-term outcomes after prostatectomy than white patients. They tend to have more transfusion, more postoperative complications, and longer length of stay. And robot-assisted prostatectomy, so short for IARP, which is not that robot that was supposed to be a dummy. It's actually an instrument that the surgeons can operate on remotely to perform the procedure. And while both robotic and open surgery are recommended treatment by the guideline, the robotic procedure has a few advantages in terms of having better visualization in the pelvic space because it's quite crammed in there. And then there's also, it also has very adroit movement with the instruments. And there's also, it also has a very small incision just to do that. So that's helpful for recovery. When comparing robotic prostatectomy versus open radical prostatectomy, it has been shown that patients undergoing both have similar survivals, but those undergoing robotic procedures, they have better short-term outcomes, such as less intraoperative and perioperative complications. So you probably know where I'm going now. Black and Hispanic patients, they have been shown to be less likely to receive IARP than white patients. And in our own study in New York State, we do find that when we looked at procedures performed between 2008 and 2018, we did find that although the differences are closing toward the later stage, the differential use of robotic procedure, it persisted over all the entire time period. And we also found that the differential use of IARP across the racial and ethnic groups was a contributor to disparities in short-term outcomes. So it really happens in two ways. First of all, the size of the bubbles here, they symbolize the size of the group. So the bigger the bubble, the higher the proportion of patients receiving treatment in this group. So here it's showing that more white patients are receiving robotic procedure. The proportion is higher than those among Hispanic and Black patients. And so by the difference of the prevalence of use itself, it's already creating some disparity in terms of the outcome because robotic procedure just have a lower risk of major events and major adverse events and prolonged length of stay. And then the second way it's rigging it is that if you look at the gap between the robotic bubble and the open procedure bubble, the gap is smaller in the white patient group than in Black and Hispanic groups. So this means if we were to offer robotic procedure to the same number of white patients and Black or Hispanic patients, the Black and Hispanic group, they are really going to reap bigger benefits. They are going to experience a greater reduction in postoperative complications and prolonged length of stay. But because they are really not getting the same prevalence of receiving robotic procedure, they're not gaining the benefit as much. So now that we know there's a difference in differential in the use of RARP, and we know that it is a contributor to the differences in outcomes. So the question I wanted to answer is, what are the possible mechanisms that could be leading to the differential use of IARP across racial and ethnic groups? And to answer that, I borrowed some multi-level framework from the Institute of Medicine. They had an unequal treatment report in 2002 in which they looked at factors contributing to racial differences in healthcare quality. So here, the reason to use that framework is robotic procedure, patients are receiving robotic or open procedure, and both of them are guideline recommended. So they are not really receiving inappropriate treatment. It's the fact that they are receiving a lower quality of treatment. And so in the report, they noted four main brackets of factors that could influence racial and ethnic differences in healthcare quality. There are clinical needs and patient preferences, access to care, discrimination, bias, and uncertainty, and operation costs of healthcare. And they consider the latter three disparities. So these factors, they can really come in from different levels. They can come in from patient levels. For example, we know that a higher proportion of Black and Hispanic patients, they have Medicaid. And it has been shown that patients with Medicaid insurance, they were less likely to receive IARP. And it could also come in from hospital and system level. For example, previous studies have shown that Black and Hispanic patients are also less likely to receive procedures, radical prostatectomy procedures at a robot-only hospital. And the surgeon level factors have never been explored. So that's where we were focusing on. And corresponding to these two type of factors, we decided to look into two hypotheses. So the first one, corresponding to the access of care, we named it segregated treatment hypothesis. Non-Hispanic Black and Hispanic patients are more likely to be treated by surgeons who are low IRP users compared with non-Hispanic White patients, after accounting for differences in clinical needs. And the second hypothesis corresponds to the process of care in which discrimination, bias, and uncertainty could arise. And we named it differential treatment hypothesis, is when patients have similar medical conditions and are treated by the same surgeons, non-Hispanic Black and Hispanic patients are less likely to receive IRP than non-Hispanic White patients. The data, so to test those two hypotheses, we used New York State Cancer Registry linked to this chart data. It turns out the New York State Department of Health can do the linkage for us, and it really allowed us to have a cohort of patients of all age groups, all insurance payers, and treated at any hospitals by any providers, including any community or academic providers. So that was really critical because to answer these questions, we really don't want a cherry-picked sample of patients. And we included adult male patients diagnosed with localized prostate cancer between 2007 and 2017 and received prostatectomy within a year. We included about 14,000 non-Hispanic White patients, 3,001 non-Hispanic Black patients, and about 1,500 Hispanic patients. We didn't include patients from other racial groups because they are relatively small and underpowered for the analysis, and we didn't really want to group them into a very heterogeneous other group, which you really cannot interpret anything. To look at the segregated treatment hypothesis, we looked at an outcome variable that looks at the type of IRP performer and account for the practicing facility type. Because if a surgeon is doing the surgery at a hospital that does not have robot or does not use robot, then they wouldn't even have the chance to do a robot surgery. So the outcome variable was had a high IRP use surgeon, low IRP use surgeon, and surgeon at a non-IRP facility. And we found that about more than 30% of Black and Hispanic patients, they received procedures from a surgeon, a low IRP use surgeon versus 23% of the White patients. And about 10% of Black and Hispanic patients received the procedures from a surgeon at a non-IRP facility, as opposed to 3% of the White patients. And when we look at the multinomial regression model results, we found that Black and Hispanic patients, they were twice as likely to receive procedure from a low IRP use surgeon and more than 4 times as likely to receive a procedure at a hospital from a surgeon at a non-IRP facility. And everybody usually I get here, they ask, what about the role of insurance? Because we all know that insurance is a factor that contributes to the lower use of technology. And so we did a subgroup analysis of insurance providers, and we did find that overall patients with Medicaid, they are less likely to be treated by high IRP use surgeons. But we also found that this pattern of differential use of segregated treatment, they really existed across all insurance types. And I was actually expecting the Medicare group to have a smaller difference, to be honest, but it turned out to be bigger than I would expect. Okay, so move on to the differential treatment hypothesis. To do this, we did a matched cohort study. We matched non-Hispanic Black and Hispanic patients individually to non-Hispanic White patients on treating surgeon, age, time of procedure, and Gleason grade group. And we looked at the individual use of IARP in a matched cohort. And the matching for non-Hispanic Black to non-Hispanic White and Hispanic to non-Hispanic White, they were done separately. And to do this, we also restricted to, so we also want to remove the factors that could be contributing to this, like they're not using because they are just treated by somebody who does not use robot. So we remove, so we make sure that the surgeons perform these procedures, they have to do at least one robot procedure, one open procedure, and they have to treat at least one racial minority and one white patient. So what we found is that we got about 1,500 pairs of non-Hispanic White and non-Hispanic Black patients, and about 700 pairs of Hispanic patients. And we found that in a matched cohort, Black and Hispanic patients, they were still less likely to receive IARP than non-Hispanic White patients. I did do a subgroup analysis by insurance here again, but I didn't show it here because, as you can see, the sample size went down with the matching. And when we got to the subgroup, the sample sizes were smaller, which means although the direction of the coefficient, the effect estimates were the same direction, but the confidence intervals were really wider, and it was really difficult to make a conclusion out of that. So what do we learn from here? I think in plain language, Hispanic Black and Hispanic patients, they are treated by different surgeons, and they're treated differently when they have similar conditions and treated by the same surgeon as white patients. And that is where I want to use the wording structural inequity. And it's because it's something that's embedded in the contextual higher level, the structural level that's affecting this, that's making this unfairness happen. And what do we mean by structural? I really like the WHO framework when it comes to explaining structural. It's something that's higher than, it's more on the macro level, such as governance, macroeconomic policy, social and public policies, the values and cultural norms we have in the society, the hierarchy, power, or prestige of certain groups in the society, and also implicit or explicit bias that we have, that's embedded in our society and our community. So looking back to this, I'd like to go through the differential treatment first because there's more to come with the segregated treatment. For differential treatment, it could really reflect some beliefs and perceptions that our medical community or our society as a whole that we have toward some people, some group of patients' behavior and understanding toward the treatment. It could also be implicit or explicit bias and discrimination that existed in the healthcare and in the society as a whole. It could also reflect the fact that our society and our medical community, I would say, have limited cultural competence in a sense that if I think about it, I would say we do lack some cultural sensitivity in terms of how we accommodate our communications or discussions with patients from different groups and how we support different people with different cultural norms of beliefs in their healthcare decision making. On that line, so a colleague from Dartmouth-Hitchcock, Jessie Colombo, who's a vascular surgeon, and we are proposing a study to look at physician workforce diversity and racial and ethnic disparities in lower extremity revascularization. And we submitted an R21 last year. It got scored 13th percentile, so we're waiting to see if it gets funded. And what we want to do is really to use this as, we're going to use the data source that I talked about before. We want to generate some preliminary findings that we can use for future studies to further engage our hospitals and physicians and patients to understand individual, interpersonal, and structural factors involved, and if we can do anything to address that. But going back to segregated treatment, that reflects a very different set of issues. It mostly, I think, reflects the fact that there are systematic barriers existing in the system and in society when seeking care. And it could also reflect the fact that disadvantaged groups, they have fewer flexible resources that they can deploy when they need to seek care. And that's when I really want to take a step forward and think about what I want to study next. And at that moment, I feel like I also need to take a step back. I came in with the technology question because I've been working on a lot of technology studies, and that's what I observed. So I started with that, but then it felt to me that something more fundamental is happening and needs attention. And it's that, yes, when we are looking at technology, Black and Hispanic and people from low income or high poverty areas, they're less likely to receive a newer technology, a less invasive technology. But I've also seen in past research and in other literature that they are less likely to receive procedures, for example, from high volume providers and from high volume hospitals. By high volume, we mean a higher caseload within a certain period of time. And volume is actually an important quality indicator. Usually especially for high-risk procedures, the higher volume a hospital has, usually the better the outcomes. And it's not just in prostate cancer, it's also found in colorectal cancer treatment. Patients from these disadvantaged groups, they are less likely to receive treatment from NCI cancer centers and high-volume hospitals. And it's also in breast cancer, and I've also seen it in non-cancer contexts. So it's also interesting to me that sometimes in some of those studies, the investigators, they put all these factors, individual level and area level, social economic factors into the same model. Not that I particularly agree with that kind of practice, but I think it's very intriguing to see that when they, for example, when they have all these variables in the same model, both individual level low social support and area level poverty turn out to be significant predictors. And that just that speaks for itself in a way that there are individual and more higher level factors both at play. So it really makes me think, those observations and findings, they really make me think that these disadvantaged patients, that these patients from disadvantaged groups, looks like they might be getting care from different providers, in the sense that they are getting care from hospitals and providers that predominantly treat them instead of other people, and other people are getting care somewhere else. And that's where I use the word healthcare segregation. And these providers and hospitals that treat these patients, they tend to be low volume, low technology users, and they are like non-cancer accredited centers. And these usually, as I mentioned before, these centers and these providers, when patients are treated by them, they tend to have worse patient outcomes. And as I read more on this topic, I realized there are also historical contexts that needs to be taken into consideration. The 1946 Hospital Survey and Construction Act, also known as the Hill-Burton Act, it was actually a legislation to address the shortfall of hospital beds at that time. And it provided federal grants to construct public and nonprofit hospitals and long-term facilities. And for a facility to receive the grant, it needed to agree that they would provide a reasonable volume of free or subsidized care to individuals unable to pay, also called uncompensated care obligation. And I think that meant well, but in practice, there are a lot of caveats. States were actually allowed to construct hospitals for different population groups, such as Black patients or low-wage workers, as long as they provide equal care. And the compliance to the uncompensated care obligation was really not enforced. So which means a lot of the hospitals were really not providing that to the patients, even though they received the grants from the government. And there's also a clause in the act that for a hospital to be built in a certain area, it must be shown that this area is economically viable, such that they can provide a certain degree of matching local funding. So this really meant that for communities and areas with very poor social economic situation, they were not really getting the grants. And the results is actually the majority of the hospital built under this act, they were built in areas with middle class families. And that provided some historical context for separate and unequal care, and unequal distribution of care, and barriers to care for certain groups of patients. And all these just led me to my ongoing research in healthcare segregation and outcomes for patients living in current poverty and persistent poverty areas. So why did I choose high poverty area as the topic? There were theoretical considerations. Of course, when I think about the contextual effect of poverty from these historical policies and the fact that these areas usually have limited economic and social cohesion, economic potential and social cohesion, and these are important factors that could lead to structural inequity in healthcare and in turn lead to disparities in outcomes. And when we look at these two maps of cancer mortality and poverty rates by county, you just see that they quite closely mirror each other. And there was also a practical consideration. When I was thinking about this research theme, SOCA had a call for application to pilot funding. SOCA is one of the 5 persistent poverty initiatives funded by NCI, led by Mary Beth Terry here and Will at Weill Cornell. So I think that really closely related to my topic, and I decided to apply. And I was fortunate enough to be a recipient of the pilot funding. So that allowed me to look at the colorectal cancer as a pilot and then scale it up later and as a foundation for my projects later on. So in the pilot, there are 2 questions we're trying to answer. First is, do certain hospitals predominantly provide surgical care for colorectal cancer patients from persistent poverty and current poverty areas? And the second is that, is this pattern of segregated care associated with worse patient outcomes among patients from high poverty areas? And so we use SEER Medicare data. The states in SEER registry is a bit fluid. The version that I used had 15 states, cancer registry, and linked to Medicare claims. The county level information was readily available, so that's why I focused on the county level poverty in the pilot. And I'll talk more about this in the later when we talk about the findings. And then we included patients with non-metastatic colorectal cancer diagnosed between 2009 and 2019 and undergoing surgery within 6 months of diagnosis. The area level, county level poverty measure was derived from census and American Community Survey. High poverty area is defined as an area having a poverty rate of 20% or above. And persistent poverty area is defined as high poverty area being a high poverty area for 4 consecutive time periods. And in this study, we used the definition by Census Bureau, which we used 1990 and 2000 censuses and 2 American Community Surveys. And for those residing in a county that was a high poverty area during the year of their diagnosis, but not a persistent poverty area, we consider them current poverty area. So the key measure was healthcare segregation, which we define as hospitals that predominantly treat patients from high poverty areas. By predominant, mean it's more than half of their patients were from high poverty areas. And the health outcomes we looked at were short-term adverse events, 30-day readmission, all-cause mortality, and cancer-specific mortality. So when we look at the effect of this treatment pattern on outcomes, we're really looking at the joint effect of area level poverty and treatment at a segregated hospital on health outcomes. And my hypothesis was that for patients from low poverty areas, those treated at a segregated hospital would have a slightly worse outcome because they received care from a hospital with worse quality of care. And for those from high poverty areas, even if they are not treated at a segregated hospital, they will still have worse outcomes because of the contextual effect of poverty. And it's really the group of patients who are from high poverty areas and get treated at segregated hospitals, they would have much worse outcomes because they are getting the contextual, if they have the contextual effect of poverty, and there is also the effect of receiving worse quality of healthcare. So just to look at the composition of the cohort, we had about 81,000 patients. About 15% are from high poverty or persistent poverty areas, breaking it down about 8% from current poverty and 7% from persistent poverty areas. And a higher proportion of patients from current poverty or persistent poverty areas, they are Black or Hispanic patients, and they lived in urban or rural locations. And we had about 1,000 hospitals in these states, and we found that about 18% of them, they treated patients, more than half of them were from persistent poverty areas, so we call them segregated hospitals. And that covered about 64% of patients from high poverty areas. And breaking it down, it will be 72% from persistent poverty areas. That's opposed to 3% of those from low poverty areas. And I know those numbers are a bit hard to wrap the head around, so I made some figures. They're about 1-to-5 ratio of those from high poverty versus low poverty areas. So I made 20 figures for those from high poverty areas, and 100 figures for those from low poverty areas. And so this is what it looks like. About 13 of those 20 from high poverty areas are treated in those segregated hospitals, and about only 3 of those 100 were treated at these hospitals. I think that told me my hypothesis was true, but also when I saw the number, it struck me a little bit. So when we look at by location and by racial ethnic group, we found that actually in metropolitan area, you would think there are a lot of healthcare resources around, but actually in metropolitan area, we see as much segregation or if anything, more segregation than in rural areas. And as probably expected is non-Hispanic, Black and Hispanic patients, the impact in this group, the segregation experienced by this group of patients is higher. And when we look at outcomes, I know there are a lot of numbers, so just to bring your attention with the colors, is that it pretty much most of the results were consistent with my hypothesis that high poverty area patients treated at segregated hospitals, they had much worse outcomes. But there was an odd result of the persistent poverty area patients treated at non-segregated hospitals. And I think I have a reason. I have an explanation. Is when I look at actually by location, this only exists in metropolitan area patients. And this has to do with the fact that a county in a metropolitan area is really big. It includes a lot of neighborhoods, and especially because I think the neighborhoods that skewed us is actually in New York City, Bronx and Brooklyn. They are persistent poverty counties. But we all know that, for example, in Brooklyn, there are a lot of different neighborhoods, and some of the neighborhoods in Brooklyn are quite well off. And so I think by using county level poverty, there's really a bit of misclassification happening with persistent poverty area. And then when we look at results stratified by racial and ethnicity, we do see that for non-Hispanic, Black, and Hispanic patients, the impact of the segregated treatment is higher. Okay, so what do I want to take from there? So first of all, I do want to fix the county level issue. So the next step really, I'm going to work with the CU Medicare and NCI to see how we can get the census tract level information for persistent poverty. And second, I do want to scale it up because I do want to understand, I don't think it's a disease specific problem, especially not within a specific cancer. So I really want to look at the magnitude of healthcare segregation across multiple cancers. And I also want to understand what drives segregation, the role of flexible resources, and if we can identify some areas for intervention. And the conceptual framework behind this whole project is really the fundamental causes theory, in that resource deployment plays a central role in the association between individual and contextual socioeconomic status and health outcomes. And these resources, a lot of time, I think traditionally, especially in the medical profession, a lot of the emphasis has been given to individual level factors such as behaviors, health literacy, knowledge, a person's ability to get care. But I think those are certainly very important factors, but I think there are a lot of things higher level, including interpersonal, community, and system level that can be addressed. And that probably would be a powerful way to address them as well. And so that's underwriting. So there are two more questions I'm very interested in understanding related to this question. I don't have an AIMS page yet, but those are just questions in my mind I will be interested in exploring. As the first thing is the impact of COVID. COVID obviously has some impact on poverty. I've read is actually the proportion of poverty in suburban areas rose after COVID, supposed to before. And then COVID also has some effect on our healthcare system, quite profound. So I really want to understand how did that affect segregation? How did that affect patient outcomes? And also if there's any factors related to resilience that we can take some lessons from. And the second thing I'm interested in is the centralization of how the centralization of care is related to the segregation of care and how it changes it. Because centralization is actually happening within the past 1 or 2 decades, is that a lot of the high-risk procedures are being centralized to tertiary and more specialized centers. And there are reasons for it. There are logical reasons for it. There are also advantages to it. And that nowadays, a lot of the procedures, they need high technology equipment, they need hospitals to have the support structure, and they need specialists. And it really doesn't make sense to have specialists like everywhere. So you'd have to, there's a reason to sort of centralize those resources to some hospitals, because then they can provide better care. And it's also, there are advantages in that, as I was mentioning before, volume is a very important quality indicator in procedural care. It's just because the process is more streamlined, people get more familiar with each other, with the team structure becomes better, the hospital support system becomes better. So the more procedures a hospital performs, they really get better at the outcomes. But then it does create some issues in terms of people need to travel longer to actually get care. And that really, as we can see, it's already people are not getting care very equally. So I'm interested in understanding how that affects it and the outcomes. So that's pretty much it. Thank you. Oh yeah, my husband and I we like hiking. So this is one of the pictures from one of our hikes that we like from Grand Canyon, where we hike down into the canyon. And I put it here because I feel like it's very fitting in the sense that in the entire environment, we feel everything is very arid. But then all of a sudden in the middle, there's an oasis. And then you can see trees and water. And that just shows like the contextual effect has a very strong power. Happy to take questions. I guess first we'll take questions.
There's nothing wrong. Okay.
There are a few, so let's see. Oh.
Rising Junior from Stone College. I'm in Atlanta, Georgia. Thank you for speaking with us. Thank you for. So as it pertains to discrimination and as cultural racism, that is something that is kind of that is hard to fight against in a lot of ways. how do you propose that we solve this issue?
That's a very tall order. Yeah, thank you for your question. I definitely agree that structural racism is still embedded in our society, and it's a very difficult issue to fight. Which I don't think we should stop fighting it. That's definitely the wrong thing to do. Just because it's difficult, we should still keep doing. And a lot of the things has to do with changing people's fundamental beliefs and how people see each other. And that I think a lot of the things are happening with our education system and our society, how we provide training and accommodation for it. But I also want to say that those things probably will take time to happen. But in the meantime, there are more tangible things that we probably could do to mitigate the effect, such as make sure people from disadvantaged backgrounds can get equal care, or at least appropriate care. And I don't think they conflict with each other. They actually, at some point, hopefully we don't have to do the intervention on the system level to really try to get to these patients, try to have these patients come to us in the same way. I guess our ultimate goal is that our society functions in a way that we don't need to intervene anymore. But I think that will probably take a long time. And in the meantime, we should just work on the things on different levels, try to bring the effect together.
Thank you for this presentation. I feel like to have a deeper understanding of the question, the structural racism itself is a way to solve it. Like it's a one more step to solve it. And my question is why? I'm curious why in the study you only include Hispanic people and non-Hispanic Black people and white, and there is no other, like no Asian include in this thing.
It's mostly because actually in the first study I talked about, we really didn't include them because those groups are really small. And when it's very small, there's just no way for us to get a conclusion out of it, because you'll see very wide confidence intervals. And then if I group Asian with Native American, or like I know people group them with group us with Pacific Islander, which I think we are very different. And even within Asian, they are heterogeneous. So like if we group all of them, it creates another group that you don't really know what to interpret for them. Like if I find an effect, does it mean that all these other group people are less likely to receive robotic technology? That's probably not true for all of them. And it feels like if I would rather just not include them in the study and have some future research that in some way we can do it properly than just have it in and have a result that I can't really speak to.
Sure. Your colleagues it could be at Cornell, it could be at other medical schools, especially for instance, it's some of the surgeons. And what they suggest? Bridge some of those disparities, which would be smart.
It's true.
Sorry, do you just mind repeating the question?
Because Dr. Branus is asking, we're in the medical campus and I work in the medical school. What are our colleagues from the clinical fields? What are their reactions to, what are their comments about this? What do they think about these results, and how do they see ways forward? I would say, actually, I've never received any answer for the last question. Nobody really told me what to do next, but what they think would be the next way forward. I did have conversation, obviously, with some of the surgeons, because we are co-investigators on these grants. And then a lot of times they start asking, oh, what is the impact of insurance? What is the issue like related to patients, their access to care? And I think that if you ask me, I think that reflects a lot of the times in the medical profession, a lot of the emphasis really had been on the individual level. And that's also what I think is different from the public health perspective. But I think it probably reflects how clinicians are educated. And we just look at individual risk factors. We look at individuals' insurance status, individuals' ability to pay, or like access to care or knowledge. And I feel like there's some gap to bridge here as well. But there are, I would say, over my work with a lot of colleagues from the clinical fields, there are people who are probably thinking more ahead of the others and thinking more toward what to do. And so I was mentioning the colleague who's working with me on the R21. And I think we had a very good conversation about this line. It's not specific to this cancer topic, but he's a vascular surgeon. But I think he does acknowledge that, for example, he's a white physician, as a white male physician, when he sees a white male patient versus when he's communicating with a Black female patient, there might be some dynamic that is not completely accommodating to some other groups that's not very aligning with his identity. And so we do both agree that there's something that needs to be done and probably can be done. And that's why we're proposing this project. And then hopefully we can work with the Society of Vascular Surgery and the registry and also hospitals to move forward. Everyone.
You have a question about it?
That's okay. Okay, so we'll go across the street now
Okay.
to the 15th floor conference room. Let me just show you.